So welcome everyone, welcome to Partners in Pain. My name is Kelly. I'm really happy to be here and I'll be your facilitator for today's session. Thank you for joining us. I'm going to start with our land acknowledgement. So as we gather today, it's important that we offer a land acknowledgement and acknowledge that we are all on treaty land. I'm joining from Treaty 6 territory, the homeland of the Métis. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. This is something that's really important to me as a healthcare provider and just, I think, as a human being. And I would like to acknowledge the importance of the relationship, and I'm committed to learning more so that I can do better. And once again, a little bit of background about our program here. So Partners in Pain, this webinar series grew out of the Improving Pain in Saskatchewan Collaborative Research Project, which was a project aimed at giving pain a voice by bringing people together to share information and plan action on improving how pain is managed in our province. And originally started off as a pilot series of webinars in March 2021, a year ago now. And from that initial pilot series came this work because of really positive feedback. So we had additional funding to support these webinars from the Community Initiatives Fund Community Grant. And that's what brings us here today. So big thanks to the fund for supporting this work, as well as Sask Pain, a nonprofit organization which is on a mission to improve the lives of those living with pain in Saskatchewan. So check out the Sask Pain website if you haven't checked it out before today. We're going to do our etiquette session too. I think we've been Zooming for a while now, so hopefully a lot of this is just helpful reminders, but please keep yourself muted while our presenter is speaking just to minimize any of the background noise. We would love to see all of your faces, keep your videos on. Sometimes if you're having connection issues, it might help to turn off your video, so that might be a time to consider doing that. There will be an opportunity to ask questions during this session. So you can submit your questions in the chat box and I'll be sure to share them with our presenter. Having had some conversations about cannabis with folks in the past, I know there always seems to be a lot of questions. So we've got 2 sessions to review cannabis. So any questions that we might not get to today, you can certainly share them with us still in the chat, pass them along to Celine or to everyone, and we will address some of those questions the next time we come together with our speaker. So definitely encourage you to submit questions about cannabis today. All right, let's move on with our presentations. It is now my pleasure to introduce you to our first speaker for today, Dr. Robert Lafrary. So Robert is an assistant professor and the GSK CIHR Research Chair in Drug Discovery and Development at the University of Saskatchewan. He is also the President and Director of Education for the Canadian Consortium for the Investigation of Cannabinoids, or CCIC. This is a tongue twister of an intro, Robert. He and his lab have been studying cannabis for the last 10 years with a focus on developing new medicines and understanding the potential risks based on cannabinoids for pain, epilepsy, and other neurological disorders. I've had the pleasure of hearing Robert speak in the past, and we are in for a treat this afternoon. So without further ado, I will pass the Zoom button over to Robert.
Thank you so much for that very generous introduction, Kelly. So my name's Robert, and I'm really excited to talk to you guys all today about cannabis and pain. This will be kind of a whirlwind tour, but like Kelly said, there will be time for questions at the end. I'm also on Treaty 6 territory today, and just doing my best to learn more and acknowledge the land that I call my home. I do have some conflicts of interest. Research in my lab is sponsored by GlaxoSmithKline, but GSK doesn't provide any insight or design input into the research that we do. I receive speaking honoraria from various organizations, and I'm a consultant for 2 pharmaceutical groups on projects that aren't related to today's talk. So using our Zoom hands, using your raise hand function, just be curious to see how many people on the call today have been interested in using cannabis for themselves, their patients, or their clients, etc. This is a safe space, no judgment here. So the majority of people are putting up their hands, and I think that's pretty normal. And unfortunately, what we're faced with today in Canada and around the world is that although certainly the majority of people have been asked about it or are curious about it, we really have very little dedicated education in this space. You won't find information on the endocannabinoid system in most textbooks within the last 5 years, although that is changing. But I like to start off by introducing this graph, kind of looking at the scientific history of cannabinoids. So cannabis as a plant has been used for thousands and thousands of years. There are written records in ancient Chinese texts of cannabis being used for pain dating back to 2,000 years before the Common Era. But it wasn't until fairly recently in our modern history that cannabis's pharmacology began to be worked out. So here in this graph, what we can see, this red arrow shows when delta-9 THC was first isolated. And put simply, delta-9 THC is the thing in cannabis that gets you high. And it wasn't isolated until 1964 by an Israeli chemist named Raphael Mechoulam. And then for a long time, I'll talk about this history in a bit, there was kind of an ebb and flow in the research, but we have to remember that this was largely during a period where cannabis was a restricted and controlled substance in every jurisdiction in the world. And so doing this research was very difficult. In 1991, we got the first cannabinoid receptor, CB1, cloned and understood, as well as our body's own two endogenous cannabinoids in the 90s, anandamide and 2-arachidonoglycerol. There was a synthetic cannabinoid that was available in the European Union and sold under the name Rimonabant. It was actually a cannabinoid receptor blocker, and it was used for the treatment of diet and obesity. It was removed from the market due to adverse psychoactive effects in the early 2000s, in 2004. And then it wasn't until 2016, actually, that we got our first look at what the cannabinoid receptors actually looked like. So when we look at this field and we compare it to other fields like the opioid field, in general, cannabinoid research is about 30 years behind comparable fields of study. So after Dr. Mechoulam had made that original discovery of THC in the mid-60s, for a long time, cannabinoids were thought to be false steroids. And the reason for this was they have a number of different pharmacological activities in the body. And the structure of some of these chemicals, such as THC that I'm circling here with my cursor, was somewhat resemblant of estrogens. Then in the 1980s, the prevailing theory was that cannabinoids simply affected the fluidity of all of our cellular membranes. And that's how they produced all of these disparate effects. It wasn't until 1988, though, that someone suggested that cannabinoids had their own receptor and that indeed humans had our own endogenous cannabinoid systems. And that work was done by Dr. Alin Howlett, who I've pictured here, one of the forerunners of the field. And she was able to show through several very well, clearly defined pharmacological experiments that these things are happening through a receptor and not through some other means. I like to divide my cannabinoids into three flavors or different types, if you will. On the left, these are our endocannabinoids. These are neurotransmitters that our body is making all the time, anandamide and 2-arachidonoglycerol. They are part of our normal biology. In the middle, these are our phytocannabinoids. These are probably the ones that we are culturally most familiar with. The two biggest players in this field being THC, which is, again, the thing that gets you high, and cannabidiol, which is seen as a more modulatory complex of molecules with a much more diverse array of pharmacological targets. And then lastly, there are the synthetic cannabinoids. Originally, the synthetic cannabinoids were developed as tool compounds to be used as researchers to help us understand the body's endocannabinoid system. Unfortunately, in recent years, they've become prevalent on the illicit market, for lack of a better description, and are now seen as substances of misuse and abuse in several developed countries around the world. So we find the receptor in 1990. It's a big deal. Everyone's really excited. This is one of the first autoradiograms showing where the receptor is in the brain. So the way this experiment was done is a mouse brain is taken and it's cut in half, and we're looking at the mouse brain from a side view. And we can see the different regions of the brain labeled, but where you have darker staining, that's where more drug is bound. And where you have lighter staining, that's where less drug is bound. And we can use this as an indirect way of understanding where relative amounts of a specific receptor are present. So this experiment would have done with radioactive THC. In 92, we get our first endogenous cannabinoid, anandamide. This comes from the Sanskrit word for bliss, which I'm showing here. And then it's not until the early 2000s that we actually work out on a cellular level what it is that cannabinoids do to facilitate their actions. Now, nobody panic because it turns out there's not a test after this. But what I want to tell you is kind of on a neuronal level how cannabinoids work. So in this picture, just to orient you, we have two neurons. Our blue neuron is our presynaptic neuron. It's the one that's going to be sending the signal. And our yellow neuron is our postsynaptic neuron, and it's the one that's going to be receiving the signal. In a normal system and for most neurotransmitters, what we see is that neurotransmitter gets released from the presynaptic neuron. It crosses this space called the synaptic cleft, where it interacts with receptors on the postsynaptic neuron, and then some response or activation, here shown by the lovely lightning bolts, turns that neuron on. Cannabinoids are a little bit different, and part of their difference is why it maybe took us so long to understand them. But cannabinoids are actually synthesized on demand in our yellow postsynaptic neuron, and then they travel backwards to the first neuron in a retrograde direction, we say, where they interact with cannabinoid receptors. Those cannabinoid receptors on that presynaptic neuron, when they get activated, their job is to turn off that presynaptic neuron. So really what they're doing is acting as a neuronal braking mechanism to slow things down in a feedback loop. Those same cannabinoids can act on astrocytes and glia that are in the neighborhood. And when cannabinoids act on those microglia and astrocytes, they limit inflammatory release or pro-inflammatory cytokine release. And so they're acting as a braking mechanism for inflammation as well. And it's through those two major pathways that cannabinoids accomplish almost all of their biological functions. In the adult human brain, we see that the type 1 cannabinoid receptor, which is the cannabinoid receptor present in our neurons, is throughout the brain. Some researchers believe it is actually the most abundant receptor that we have in our brain. But where we see levels of it being highest are also areas of the brain where we can associate its action with what happens when a person becomes intoxicated on cannabis. So, for example, in the cerebellum, the substantia nigra, and in the putamen and caudate nucleus, as well as cerebral cortex, all of these areas are involved in motor coordination, as well as learning and memory. So a person that's intoxicated with THC, they might see reduced motor coordination or reduced short-term memory. We also know that cannabis can reduce anxiety in some individuals. Those functions are occurring through CB1 activation in the amygdala. And we know that for many people, cannabis stimulates appetite, what some of us might refer to as the munchies. That's happening because THC is stimulating CB1 receptors in the hypothalamus. Now, as I mentioned earlier, cannabis has been used medically and recreationally for a long time. But I want to take this slide to dispel some myths. So first of all, there is no genetic difference between cannabis sativa, cannabis indica, and hemp. It is all cannabis. What makes it fundamentally different plant to plant is the proportion and amount of different cannabinoids present in that plant sample. But you can have indica that has a lot of THC, you can have sativa that has a lot of CBD. That's really just a label that's been put on there by growers. It has no scientific bearing. At the end of the day, it's really the cannabidiol and the THC that are the primary pharmacological drivers, just like alcohol is the primary pharmacological driver in wine. Cannabis also contains terpenes. These are the things that give them different smells, but really all plants contain terpenes, and we don't have any strong evidence to date to suggest that that has any bearing on the pharmacological effect. And then finally, as a species, human beings are super good at finding things in nature that affect our perception of reality. And so here on this slide, I have cannabis right here in the middle, but I also have a coca plant, which is where we get cocaine, an opium poppy, a tobacco plant, and a mescaline cactus. All of these are naturally sourced things that have effects on our mental state. So natural does not equate to safe. If you take away anything from today, please take away this. THC is the thing in cannabis that gets you high. It does that by activating the type 1 cannabinoid receptor, or CB1. It's an activator of both CB1 and CB2. Cannabidiol has multiple mechanisms of action. It seems to have anxiety reducing and inflammatory reducing effects, but cannabidiol cannot get you high. A big question right now in the field of cannabis research is what's called the entourage effect, which is this idea that somehow the complex milieu of different substances found in the cannabis plant is somehow better than an isolated pharmacological ingredient. And there are some important questions that we have to think about when we look to this complex mixture of things found in a cannabis plant. So are there interactions occurring? Are those interactions beneficial because maybe they're harmful or maybe they don't matter? And then finally, how reliable from plant to plant to plant are the consistency of those products going to be? I'm going to change gears a little bit here. This is just a pretty picture to remind me to change gears. This picture was taken by my colleague Tegan Quillanchini at the synchrotron here in Saskatoon. This is the bud at the end of a cannabis plant. And these little vesicles are where the cannabinoids are stored at the end of the flower. So this is taken on a synchrotron microscope. And it's just a pretty picture. So we're here to talk about pain. I've given you guys a lot of background. Now I want to tell you how cannabinoids moderate pain. So CB1, our receptor that deals with neurons, it's present in our spinal cords. And here we have this lovely image from a review article and a zoom in on the spinal cord. And we have nociceptive neurons. The nociceptive neurons are going to travel from the rest of our body up into our spinal cord. And they're going to send information to our brain telling us that something hurts. On those neurons, we have our friend, the cannabinoid receptor. It's this little red square on this image. When that cannabinoid receptor gets activated through the same mechanism that I already mentioned, it's going to tell this purple neuron to put on the brakes and slow down. And so in that way, less painful information is able to move from your body up into your brain. And that's the primary mechanism by which cannabinoids stop painful information from ascending. It's actually the same mechanism that opioids use. So here we see our friend, the mu-opioid receptor on the exact same neuron. Other mechanisms include activation of GABAergic neurons, and this allows for pain relieving information to travel better from the brain to the body, as well as mechanisms related to, sorry, someone's trying to get into my office. Mechanisms related to the information, mechanisms related to the breakdown of endogenous cannabinoids. And one possible mechanism for how acetaminophen works is actually by inhibiting the breakdown of endogenous cannabinoids. So this is the same idea or image displayed in a slightly different way. But here again, we have those peripheral nociceptive neurons, and they're going to be activated by painful information. And then in the spinal column, our friend CB1 is going to block the release of painful nociceptive signals. And so we sense less pain in that way. There have been a lot of interesting studies exploring cannabinoids and clinical trials. Cannabis and cannabinoids, though, we have to remember, were prohibited for a long time, were controlled substances for a long time, or still are. And that makes research challenging. So the critiques I'm about to give you about cannabis research aren't to disparage those researchers. It's just to say that that was tough. It's still tough. So we need to realize that when we understand past research in this field. So we tend to see studies with low power, which means few patients, a lack of blinding, so patients generally know what they're taking, a heterogeneity of disease, so we might see clinical trials with multiple types of pain lumped into the same study, a heterogeneity of drug, so what cannabis is being used at our site versus another hospital might differ, a heterogeneity of route of exposure, so maybe at one site they're ingesting oral cannabis oils and at another site they're smoking. Dosing criteria, one of my favorites was a study I read where dosing criteria was based on the number of puffs you took on a joint. It's not the best way of measuring things. And little to no pharmacokinetic assessment, which means we aren't really sure how much drug is getting into the brain or the blood or being excreted. So it's a work in progress. As of Monday, when I last looked, clinicaltrials.gov had 161 registered clinical trials. The vast majority of those, so this is cannabis and pain, the vast majority of those 161 aren't published yet. They're either in progress, recruiting, or haven't published their results. 82 randomized control trials have published their data, and they've explored everything from neuropathic pain to fibromyalgia to rheumatoid arthritis to neuropathies. They have all kinds of different routes of exposure, all kinds of different kinds of cannabinoids, and really there is a whole mixed bag of things going on. So in the next few slides before I wrap up today, I'm going to take you through a big meta-analysis of kind of what the big take-home messages are. And then this weekend, you guys can read all 82 randomized control trials. So for chronic pain, it seems like if we look at the gestalt of those 82 trials, there's moderate quality evidence to support the use of cannabis-based medicines for treatment, but never as a first-line choice. And for rheumatic disease and fibromyalgia, really right now, there's not enough evidence to recommend cannabis-based medicine for symptom management. This is a really excellent review of these studies. It's a systematic review of systematic reviews. And what they conclude is that there's reasonable evidence to support the idea that cannabinoids improve nausea and vomiting after chemotherapy. They conclude too that there's some uncertainty about whether or not cannabinoids improve pain. But if they do, they saw the greatest effect specifically for individuals suffering from neuropathic pain. And generally, the reported average was about a 30% reduction in pain. The authors also note that across the board, across these studies, minor adverse drug reactions are very common. So these can include things like intoxication, headache, trouble sleeping, meaning that there needs to be considerable benefit to outweigh the adverse drug reactions. A big question that I get when I present this information to others is cannabis addictive? The simple answer to that is yeah. Yeah, it is. It might not be as addictive, say, as nicotine in cigarettes or alcohol, but generally we see about 9% of chronic users of cannabis will go through some kind of withdrawal, or they'll show signs of cannabis use disorder. So generally we say about 9%, and that 9% is skewed especially towards young adolescent males in particular, or just individuals under the age of 25. In 2017, a report was commissioned in the US. It's this report right here that I'm showing on the right-hand side, to look at kind of where things were, the state of the field, if you will. And what they did was they wanted to have 4 wide sweeping recommendations for cannabis research: address research gaps, improve quality, improve surveillance, and address research barriers. And these are kind of, fundamental ground foundational pieces that we need in order to move the field forward. I like to provide some practical points to end on. The first one is called the Lower Risk Usage Guidelines, or the Lower Cannabis Risk Usage Guidelines. These are put out there by the Canadian Association of Mental Health. 10 guidelines of kind of, if you're going to use cannabis, how that could happen to put you at the least risk. So they're very simple and basic things to follow. Things like don't use synthetic cannabinoid products, which I mentioned briefly. Don't smoke cannabis if you're pregnant. Avoid higher THC products if you can. And these are all publicly available. And they also come in a kid-friendly version called the Blunt Truth. Excellent resource if you want to talk to your kids about it. About 30% of all Canadians have used cannabis. We are one of the highest using countries of cannabis globally. And about 16% of us as Canadians use regularly. Cannabis doesn't have a registered DIN or natural product number, so it is not covered by most health insurance plans, although I have heard of some exceptions lately. If you're in Saskatoon like me, don't use it in public. You can gift it, but you can't sell it, and you have to be up to 19. You can grow up to 4 plants in your own house. Great gardening project if you're interested. Some resources to point you towards. As Kelly mentioned, I'm the president of the CCIC. We have an educational platform. We also now have CE accredited modules for pharmacists and physicians that are available through our website. The Canadian Pharmacists Association has their own program, as well as the Cannabinoid Research Initiative of Saskatchewan has information on our website that I'd be happy to share with anyone. So this is my last slide, I promise. Your body has an endogenous cannabinoid system. THC gets you high, CBD modulates. Cannabis use should be avoided if you have a family history of substance use disorder, psychoses, or baseline balance problems. And for the context of pain, it's not currently considered a first or second line treatment. As with many medications, the advice usually is start low, go slow. And remember just to have open, non-judgmental conversations. Like I said, 30% of Canadians have tried cannabis. That's like a lot of Canadians. And then finally, if you do choose to use cannabis for control of pain, watch out for nausea and withdrawal, and escalate or taper dose gently. Don't just go for a big dose right away. Science is a team sport. I didn't talk necessarily about my lab's research today, but we got a lot of research going on in the lab. It's a busy place. So I just wanted to acknowledge all of the funding support that we have in my lab, as well as all of the awesome people that are working right now as I speak on all sorts of problems related to cannabis and cannabinoids. And that's it. That's all of my things.
Awesome. Thank you, Robert. That was a lot of great information. So thanks for sharing that. I'm going to give folks a reminder that if you have questions for Robert, pop them into the chat. You can either send them to everyone in the chat, or you can send them individually to Celine. You can send them to me too if you're interested. And like I said, if there's questions that pop up or things that you think about between now and our next session on cannabis, reach out to Celine, because we'll have Thaisa from RX Files speaking to us next. She's coming with some of these practical tips on what does actually using cannabis look like. So a little bit of what Robert just touched on. So bring those questions to us for the next session, and we're going to answer those questions. I'm just going to have a quick peek on the chat to see if there's any questions. I have a couple for you, Robert. First of all, I was just interested, you mentioned some resources that CCIC has for healthcare professionals and folks. Does the CCIC have resources for people that are using cannabis for pain, or, you know, I guess I use the words like patient friendly, which is actually like Kelly friendly language. But, you know, do you have resources like that available?
So we have partner organizations for kind of patient or other people friendly resources. One would be through CAMH, or the Canadian Association for Mental Health. So they have those lower risk guidelines, but they also have other patient brochures available. And then we have partnered with the Toronto Cannabis Consortium, which is kind of like the Toronto equivalent of CRIS. And they have 5 dedicated anesthesiologists on staff that are developing similar programs and protocols. I'm hoping they get to show them off this year at our annual meeting on April 20th. So.
Okay. And then those would probably get posted or linked somehow to your website.
Yep.
Okay. Yep. Awesome. Okay. I'm going to ask you to gaze into your researcher crystal ball right now. As a pharmacist, I know that we've got a couple of prescription products for that kind of are based on or are cannabinoids, right? Synthetic cannabinoids. And it was interesting to me, like this is something that I learned today, that this research is relatively new. Like it's as young as I am, right? It's only like within the last couple of decades that we've really learned about THC and CBD. Yeah. And as a pharmacist, I really heavily rely on good research so that I get products in my hands that I can then go on to use for folks that are living with chronic pain. So knowing where we're at in research and knowing where we need to get, like, what are we kind of looking at? When can we expect to start to see more, you know, products on the shelf, whether they're prescription products or like things beyond just the recreational products that we're seeing out there? What do you think?
Yeah, I think probably 5 years is my best guess at this. Cannabis is weird because for most products, if we think about, I don't know, let's say acetaminophen or an NSAID like Advil, you know, that went through a very traditional route of animal studies, and then we're testing in phase 1 and phase 2 and phase 3 clinical trials, and then now it's in people. And then we have that rigorous evidence base. For cannabis, we have a lot of anecdotal evidence that kind of pours in because people are using it actively in the wild all the time. And then we have to take that evidence and try and distill it down almost backwards into a controlled trial. I think we'll see more and more of those pharmaceutical grade cannabinoids pop up on the shelf as more evidence emerges. Because right now, even for Nabilone, which is synthetic THC, or Sativex, which is a 1-to-1 combination of synthetic THC and CBD, the evidence base is really weak. But it is much easier to do a clinical trial with a purified THC than it is to do with a plant product that you have to grow and then assume that everything is equal in both plants all the time. I don't know if that answers your question fully.
It does. And it kind of speaks to, like, it's interesting for me, I guess, working as a healthcare professional in the field where I'm really used to having more information to give people when it comes to talking about medications, right? And I find that I give people as much information I can as with cannabis, but it's different than when I'm talking about, say, some of the other prescription medications that we have for pain, for example. Yeah. Okay, here's my other question then for you. You did mention some of the uses for cannabis, like health applications, and that there is a role for it in managing pain. And you did touch briefly on, one of the side effects or maybe harms, the addiction part of cannabis. And I'm wondering if there's any other like specific side effects that you would like to see more research go into. And I think part of where my question is coming from, that rimonabant. So one of the prescription products that came out, the reason it was pulled from the market was because we saw an increased risk of suicidal ideation.
That's right. Yeah.
So we talked a little bit about, some of the potential benefits. What kind of research do we need to do into harms? Like, what are you thinking about when?
Yeah. So I think globally, when we look at cannabis research from a global perspective, where we need to be exploring harms is, I think, particularly among vulnerable populations. So there's good evidence already to suggest that cannabis use in individuals under the age of 25, and specifically, THC use under the age of 25, is more likely to be associated with addiction. That evidence is there. What is starting to emerge is that cannabis use and THC specifically under the age of 25 is also highly correlated with mood disorder development, specifically predispositions towards bipolar and or depression. So I think that is where we need to watch out, is for our vulnerable younger populations. That needs to be a major consideration. In terms of other areas, the rimonabant was interesting because that one really, it got rushed through to the market pretty quickly. Rimonabant, though, is, I would say, it's like the opposite of THC. So THC gets you high. Rimonabant is the opposite. It blocks those receptors. It reduces your appetite. And there was actually a massive uptick in suicidal ideation among patients that were taking rimonabant, which is why it got pulled.
Okay, awesome. I see a couple of questions in the chat. So one question that we got is, can you speak to how to find a healthcare provider who would be open to conversations about medical cannabis? It's a great question.
So I guess my hope is that most healthcare providers would be open to discussing it. And if not just discussing it, then pointing you towards someone else who might be interested in helping you with that. Really, the fact of the matter, as crass or as blunt as this might sound, is any adult can go and buy cannabis for themselves. So I would hope that a experienced healthcare provider would say, here's a person that's come to me and wants to do this together rather than on their own, and I can help and counsel and guide them. Someone else asked a related question to this that I'll just answer. You don't get a prescription for cannabis per se. You get an authorization to use, and it's slightly different language, but the authorization then allows you to go through a licensed cannabis provider to purchase your cannabis. But ideally, you should be doing this as an ongoing conversation with your healthcare providers, either your your family physician or your pharmacist.
And this, I think, will probably be something that Thaisa from RX Files will talk a little bit more about next week too, some of this information. And I agree with you, Robert. Sometimes it's you might have to, your healthcare provider might not have the information, but can refer you on to someone. And this is something that I know I work for a drug information service. Here's my shameless plug portion of the webinar today, guys. MedSask, we are happy to answer questions about cannabis if you have cannabis specific questions. So there are some resources out there. So it sometimes takes a few, tapping a few shoulders, but there is information out there. So keep asking the good questions because they're great questions. Okay, anything else for Robert? I could just keep chatting, Robert.
Yeah, no worries.
I'm going to keep things moving along. We are going to move on to our the next portion for our webinar this afternoon. Once again, big thanks to you for being here and for sharing that great information. So next, it is my pleasure to introduce our person with lived experience to speak. So our speaker today is Alexandria Pavelich. Alexandria is a current patient partner and PhD student working alongside Sask Pain and on various pain-related research projects being conducted through the University of Saskatchewan. Alexandria's personal history of living with chronic pain, such as hemipelagic migraines, multiple herniated discs, sciatica, and persistent pelvic pain, inspired her involvement with pain research and advocacy. Her name might sound familiar because she's hosted several amazing episodes of the Your Partners in Pain podcast, sponsored by Sask Pain. And maybe we could share that link today if you folks haven't listened to the podcast. That would be awesome, Celine and Alexandria, to share the podcast links. After many years of suffering, Alexandria now reports a pain-free lifestyle, which she hopes to help others attain by sharing her story. So Alexandria is here today. We're going to chat. She has also pre-recorded her story for us. So I'll have Celine play the video, and then Alexandria will be here to chat after the video.
My name is Alexandria, and I am a current PhD student at the University of Saskatchewan, and I am also a volunteer and board member with the Saskatchewan Pain Society. And like many of you here, pain has been a large part of my life for the majority of my life. I am only in my mid-30s, but my earliest memories are actually of being in pain. I remember having really extreme growing pains in my legs when I was quite young, and I broke my leg when I was around 3 years old. So pain has always been present. And in my early years, I suffered from stomach cramps, lots of weird muscle pains that no one could explain. I had a sporting accident in early high school, and I developed what they told me was called Coccydynia, or inflammation of the coccyx bone, which is the bone at the very tip of your tailbone. So I couldn't sit in class, which was very disruptive and stigmatizing as a young teenager. And at the end of high school, I developed migraines, which were very severe. I would frequently have to go to the emergency room for IV medications because I was so sick from the pain. And at my worst point, I had a migraine that lasted for about 6 months straight. And I was hospitalized to try to get that under control, where I was actually overdosed on pain medication in the pediatric ward. And that's where my initial mistrust of the medical institution began, as I was a bit traumatized from that experience. So doctors didn't really know what to do with me. And so, like a lot of people, I got sent to psychiatry. And not to my surprise, they couldn't help me or give me any explanations behind my pain either. But my pain sort of came and went throughout my 20s. But then in my late 20s, I herniated 3 discs in my back, L3 to S1. So imaging showed that I had massive disc bulging, annual tears. They told me I had degenerative disc disease, scoliosis, and severe arthritis of my lower lumbar spine. And that's not something you want to hear when you are 28. It was so bad that I couldn't put on my socks or my underwear for weeks. I was bedbound, and no medication was helping this horrible fiery pain shooting from my lower back to my toes, with leg numbness on the right side that would basically take my breath away if I moved in the wrong way. I was a complete mess. And this was nonstop for about 7 months, and my life totally fell apart when this was happening. And at that time, I had multiple doctors tell me I needed to get surgery right away, or I was going to have permanent nerve damage. And because of the experiences I had had with doctors previously, I wasn't convinced they were going to be able to help me get pain-free. They were telling me stuff like, if the first surgery didn't work, well, they could do it 3 more times, a microdiscectomy. And if that didn't work, they would fuse my spine with metal rods, or if that didn't work, they could put a neuromodulator device in my back to stop the pain signals. So all of these really invasive options, and they didn't really offer me anything else, which I was a bit suspect about. They offered me opioids, but when I said I didn't want surgery, they kind of just sent me on my way, not even with a physio referral or anything like that. So after that, I started looking into other treatment options for my back. I ended up finding an online rehabilitation program. And I said, I'm going to try this for 3 months. And if it doesn't help, then I will get the surgery. But luckily, I completely fixed my back pain, and it took a lot of work, but I was not only moving again, but I was pain-free and the strongest I had ever been in my life. I can share that online program with you if you wish. And the success of being back pain-free lasted for about 1.5 years. And it felt so good to prove the doctors wrong. I'm saying, look, I did this thing that you told me was impossible without surgery, but here I am. And then when I was 30, I started getting pelvic pain. And this is a very sensitive topic because it's tied to things like voiding and sexual activity. And it's a private area that we don't really talk about. And I went to the emergency room dozens of times because I kept thinking I was getting urinary tract infections. But after the 6th round of antibiotics, I sat down with my family doctor and was like, what is going on? We reviewed all my tests, and he said, none of your cultures have come back positive for an infection. And all these doctors were just giving you antibiotics that you didn't need. So, well, you're going to send you to a specialist. So for the next 2 years, I saw everyone imaginable. Because they couldn't explain it. I went back to see 2 spinal surgeons, and I said, could this pelvic pain be from my back? And they said, no. I saw urology, 3 gynecologists, 2 neurologists, an endometriosis specialist, 6 pelvic floor physios. Then I also went to non-Western medicine. I saw a naturopath, an acupuncturist, massage therapist, osteopaths. I saw everyone that you can see, basically. And some of the diagnoses that I got were IBS, pudendal neuralgia, Levator-Ani syndrome, piriformis syndrome, provoked vestibulodynia, vulvodynia, pelvic floor dysfunction, interstitial cystitis, central sensitization, fibromyalgia, suspected endometriosis, but I would need a surgery to confirm it, which I didn't want to do. And basically all these chronic pain diagnoses that had no explanation or straightforward answer for how to help. But a big red flag for me was the fact that every doctor was telling me that I had something completely different, and none of them had any options that really helped the burning and aching and discomfort I was having in my pelvis nonstop. And I was very depressed and hopeless. It was a fight to get out of bed every single day after dealing with this nonstop for 18 months, which was made worse by the fact that doctors were telling me I would just have to adjust with a life with pelvic pain forever. And I refused to accept that. So in winter 2020, I attended a live lecture with Dr. Gabor Mate, and he said in the seminar that very few care providers recognize the connection between adverse childhood experiences, so things like bullying, divorce, abuse, assault, living in poverty, and how this affects our health. And then he started talking about chronic pain and how that has a strong correlation to trauma, which got the wheels turning in my head. And this is something that no one had ever brought up to me before. Not one of these doctors had ever asked about my early childhood experiences or the current stress in my life. And it was like a light bulb went off for me. And I started reading Dr. Gabor's books and other recommendations that he gave me about chronic pain specifically, which were Dr. John Sarno, Dr. Howard Schubiner, and Alan Gordon's work. And he's a social worker, and they're all focused on the mind-body connection. And when I went back through my life history of chronic pain, I could pinpoint how every single major pain experience I had was directly tied to a highly traumatic and highly stressful time in my life. And this might sound really radical, but when I first injured my back in high school and I couldn't sit, I was the target of horrendous bullying at that time. When I had that months-long migraine that occurred shortly after I was sexually assaulted, and when I herniated the discs in my back, I was in a stressful relationship, living in a city I didn't want to be in. My university was on strike for 6 months and I couldn't work, and I felt very trapped. My back pain, which I thought had improved from the physio, well, it was actually gone almost instantaneously after I left that toxic relationship and moved away from Toronto. And with my pelvic pain, it started when I was completely overworked, really stressed out in an emotionally abusive relationship in the middle of a pandemic, trying to finish a graduate degree with all these doctors telling me terrifying things every single day. And I can remember the exact moment that I realized that my pain was so much less about what was physically happening in my body as much as it was my mind and body reacting to the circumstances around me. And I began to understand that my body was sending off a danger signal to really wake me up, to try to protect and distract me from the world around me and the emotional and traumatic experiences I was trying to endure and the unhealthy ways I was trying to manage them all, which was to frantically avoid the pain altogether and numb myself out. So my nervous system was completely overactivated or completely shut down. It was very bizarre, but when I started to think about it, I also remember when I was revisiting some of the spinal surgeons to ask out after my pelvic pain, they ran a ton of tests, MRIs, CTs, fMRIs, everything. And they said to me, do you know that you have herniated discs in your back? And I said, yes. And they said, but you don't have back pain. I said, no, not at all. I haven't had back pain for years. And they were very baffled. But the morning after I'd seen these surgeons who asked me about my back, I had full-on sciatica and back pain like I hadn't had for years, which made no sense. But it was gone within a few hours. So this just goes to show how suggestive our mind really is. So after I got onto this line of thought about trauma and chronic pain, I had to start challenging myself to really take care of myself physically and emotionally, sleeping better, forcing myself to be active, forcing myself to be social, and not 100% focusing my entire day around pain management and avoiding things that I thought was going to trigger it. So I had to stop my pain journaling and body and diet tracking which is something that like so many people said I had to do in order to control and manage my pain, which was the opposite. And one big thing that I also did was starting to take medical cannabis because it was one of the only things I hadn't tried yet. But because I was so anxious, I couldn't even begin addressing my trauma or doing my pain management because my nervous system was so hypersensitive and I was scared of everything. I was paranoid that any interventions doctors gave me were going to cause more harm. And when I started taking CBD, which my GP just prescribed, I could actually give my mind a moment to take a break and relax and start sleeping better. And once I started doing those things, my pain started decreasing and my anxiety went down because of the medication. And I started doing some more work and getting back to everyday life. And I wasn't so focused on my pain. And another important thing I did here was that I started seeing a pain psychologist at the Pain Psychology Center in LA, who I saw remotely. And that was instrumental for me because I needed somebody who really recognized that mind-body connection and it could explain to me that when your brain feels unsafe, your body feels unsafe. And when your brain starts to fire pain signals as an alarm system, realizing that really changed my life. And you have a history of things like neglect and abuse, this alarm system is amplified. So I had to start addressing the root cause of all of that, which was probably in many ways more difficult emotionally to deal with than just living with the physical pain I was trying to manage. And another big part of that was an amazing phone app called Curable, which provides tons of pain education and how that ties to mental wellness. And while I was 90% pain-free after 2 years, I was still having some issues with my pelvis. So I continued to see some of my care team because I had a great GP, I had a great gynecologist and a pelvic floor physio who would really listen to me. And they looked at my entire history and helped me problem solve and trial certain approaches that I was comfortable with, which was essential because I had had a lot of people initially say they couldn't or would not help me because I was not compliant about taking pain medication or wanting surgery, but it turned out I didn't need those. And I remember one of the specialists I saw had sent my case to someone specialized in pelvic pain in Montreal, which I had completely forgotten about because I had started feeling so much better. But the specialist called me out of the blue one day and said, I reviewed your files and your imaging, and you have pelvic venous disorder or pelvic congestion syndrome. And this is when blood pools in your pelvis because your vascular system isn't working properly. It's a common genetic occurrence that causes inflammation and pain from pressing on your internal organs in your pelvis, and it can cause a whole host of issues. And I was shocked because I remember I had thought I might have had this when I asked doctors about it in Saskatchewan a couple of years ago, but they didn't know what I was talking about, so it was dismissed. But this Montreal specialist told me I couldn't get treatment in Saskatchewan, but she did connect me with a clinic in the UK. So I booked a flight and got on a plane in the middle of a COVID outbreak happening in London. And I went and I got this treatment. And I'm now happy to report that I am 100% pain-free following the procedure I had there. And I don't have any of these issues I've been having for over 25 years now. So no migraines, back pain, sciatica, growing pains and cramps. I've had absolutely nothing for almost 7 months straight now. And I'm sharing this last piece because I think it's important to emphasize that you know your body better than anyone else. Even though I had improved enormously from the mind body work I had done, I was still struggling a little bit, but I had been right all along, even though the doctors had dismissed me. So if you are in a position where you know something is wrong with you and you have a pretty good hunch about it, follow through on that. And if no one is listening, find someone who will sit with you and hear your story and run the tests that you need. And it's exhausting and it's unfair, but pain patients have to fight so much for themselves and educate themselves as well, because pain just isn't well understood. And for me, being persistent and having that final procedure changed my life, but also leaving that toxic relationship I was in helped me learning boundaries, learning to not be such a workaholic or a perfectionist, being kind to myself when I'm really stressed, learning to lean into pain as opposed to trying to frantically run away from it. It made my pain manageable when I was hardly functioning for so many years. So to bring this all full circle, and this might sound wild, but I'm really grateful for what has happened to me because I learned so much about myself. I'm a much stronger person now, and I learned self-compassion. I learned to cultivate mindfulness and presence and to have more empathy for others. And especially that things do get better if you persist, because the brain is neuroplastic and you can rewire those pain signals, which my back is a testament to, because my imaging says I shouldn't be walking and that I need surgeries. So at the end of this all, I just want to say everyone's pain journey is unique because pain is so complicated. And some of us have really solid diagnoses that respond easily to some therapies, while some of us are a bit more complex. But no one is going to fix you, and you are going to have to fight for it. When you're living with chronic pain, it's really up to you to help yourself, and you can seek and get support as it's provided to you. But I don't think that any healthcare provider is going to swoop in and solve all of your problems with a diagnosis, a prescription, or a surgery, because pain is too complicated for that. And instrumental in my overall healing was addressing my past trauma and current stressors. And I want to clarify that trauma doesn't need to be big things like rape or abuse. Trauma can be things like feeling excluded, living under financial stress, feeling unheard or unloved or unseen by the people around you. The mind-body connection is very real. And if someone says the pain is all in your head, don't accept that as an answer, but be curious about what may be lurking under the surface in your past or everyday life that may be making your pain worse. And I think the last biggest piece of advice I can give is that don't hyper focus on trying to fix yourself. I became obsessed with my pain, and managing it and learning about it became a full-time job, which almost ruined my life. And when I let go just a little bit and started doing normal everyday things again that I was scared of doing, I started to improve right away. So that was long. I think I answered all the questions I was supposed to, but I'm happy to connect with anyone about some of the resources I have found, whether that's books or thank you to each and every one of you for listening to my story. I know there was some negativity in there, but this is my truth and this is what I've experienced. And I feel I have healed in so many ways after struggling with pain for the majority of my life. So I encourage you to be brave and think outside the box as you navigate your pain journey, where you can absolutely improve and heal from the things that doctors may have told you. You just have to accept and live with, because that is not true. And I am a testament to that.
Oh, Alexandria, that was an amazing story. Thank you for sharing your truth. These stories are just such an important part of these webinars, and so amazing and really moving. And I was taking notes and I felt like that whole presentation, there were so many amazing things that you said that are important, know your body, and know your body, and trust in this. And so thank you for sharing. If anyone has any questions for Alexandria, feel free to pop them in the chat. I'm just quickly catching up with them. Alexandria, I have a couple of questions for you. And trauma is something that I've been learning a lot about as a healthcare provider as well. And I heard someone speaking about it, saying that persistent pain is trauma, right? Persistent pain is trauma. And I think that these can be tough conversations to have. And I really appreciate your honesty and how candid you are about having the conversations. And I'm just wondering if you have any thoughts and things that you might be able to share with everyone here about ways of feeling safe in having these conversations. Like, what makes you feel safe And what do you need from the people around you to help you feel safe to have these conversations?
Thanks, Kelly. And thank you for everyone for all the kind feedback that's coming into the chat. I think a big part of that is realizing that when you're a patient in a healthcare interaction, you are like in control. You're not always, but you have the ability, if you're not feeling seen and heard, you do not have to accept care from that person and you have to find someone else. A big thing for me was starting to go to therapy so that I could learn to self-advocate for myself, because if you're not able to voice that you don't feel comfortable in a care interaction and that you need agency and that this needs to be a joint collaborative effort, you're not going to get anywhere. It's going to be two people just doing this and it's a waste of everyone's time. And I think being able to meet with a therapist to learn how to have those interactions, because they can help you like learn how to stand up for yourself, because I didn't know how to do that when I started this journey, which is why I kept going back to the ER and kept getting dead end answers. And I think a lot of anger and frustration comes with that. So even just being assertive, like it's hard, but you have to stand up for yourself because you're the patient, you're there seeking the healthcare, you have the power to do that. So if you're not getting what you need, just use your voice, but politely if you can, which doesn't always happen. I've been there. So.
Yeah, so you found that working with a therapist really helped you to find that voice, hey, and have those conversations. Yeah, my Instagram feed is full of like how to have good conversations. Skill there, isn't there? Yeah, I see some questions in the chat, Alexandria, about some of the specific treatments you've had. So maybe you can share some of those after. I'm going to go back to Jessica's question and recognizing that our theme for the session today was around cannabis. And I'm just interested to hear, it sounds like you've tried many things, lots of different therapies involved, and you've been really open to a lot of different types of therapies. And I'm just wondering if you've had conversations about cannabis with healthcare providers or with other folks living with chronic pain, what those conversations looked like, and where that's kind of fit into your treatment with chronic pain, or your treatment of chronic pain.
For sure. Well, I had heard tons of like anecdotal evidence from people in my life, whether that was family members or colleagues saying, well, have you tried cannabis? And I actually do research with veterans who have chronic pain. And in our research project, so many of them were getting off opioids and swapping to medical cannabis to treat their PTSD and their chronic pain. And so I got very interested, but nobody had really suggested that to me. But when I asked my family physician, he's actually one of the only medical cannabis prescribers in Saskatchewan, which I didn't know until I asked him, like, what do you know about cannabis and chronic pain? And he actually prescribes through something called National Access Cannabis, but I think they've changed their name now to the Clinic Network. And so when I asked him about this, he knew like I had a history of anxiety because I've had trauma in my past. So I was very anxious about, trying a new medication because I had heard some of the things like Dr. LaPrairie had said that it can actually make your anxiety a lot worse. But my doctor advised me to go to the Clinic Network to have an assessment. And what they basically do there is they sit down, they go through your whole health history, whether that's psychiatric history, medical history. You can ask a million questions, and then you get to meet for like an hour with a medical cannabis like expert, and they answer all your questions before you decide what you want to do. And I told them, I'm really anxious. So like, can this actually help me? And they're like, yes, and they make you a very specified care plan. And a big part of that was also, I felt very trauma informed because they're asking things like, do you have a history of assault and things like that. And they are taking all this into consideration because you are taking something that's slightly mind altering in a way. I don't take anything with THC. Mine is pure CBD oil that I take. So I have never felt high. I have never had any negative side effects, but my anxiety and my pain absolutely went down. So I can also send a link to the Clinic Network. And I believe I think maybe somebody else might know the answer to this. If you get a referral I don't even think you need a referral from your GP to contact them, and they can just meet with you and answer your questions and chat if anyone's interested. I learned a ton in that 1 hour assessment. So I don't know if that answered your question, Kelly. I kind of went all over the place there.
It did. And maybe that's something that we can look at for next session is just what are some options for accessing more information about cannabis. So I can take that to Thaisa. We can include the link that you're mentioning and some of the resources that Robert mentioned too. And then the resource that I mentioned, that might be a good thing for us to chat about next session. And then Alexandra, if you want to reach out to Donna specifically, she had a question about the treatment you had. And I saw another comment about where does one get therapy to become more assertive? And as I read that, I was thinking there's several members of our planning committee in the session today, maybe a webinar on conversations, right? And advocating for yourself is another opportunity. So I see some heads nodding and some note taking. So I think that might be a good session because I actually don't know the answer to that. I'm not sure if anyone here does, but we could maybe have a whole webinar dedicated to conversations and advocating and how to have like tough conversations. Okay. Oh, it's 3:01. I've already gone over time. And this is always the hardest part for me, everyone, is closing up because I would love to keep going. I am going to do our housekeeping and closing though right now. Once again, the recordings of the webinars will be available on the Saskatchewan website. The link to those will be shared with you by email. And please share this widely, right? We're really working on building our network. So share this information widely and invite others to watch the webinars as well. An email will be sent out to you tomorrow with any slides or handouts that our speakers will be sharing. It will also include a link to an evaluation about today's session. So please be sure to complete the evaluation and provide us with your feedback. To let you know, the webinar schedule and topics for sessions in May and June will be released shortly. So please watch your email for details. And once again, share that widely with any friends, colleagues, family members, anyone. Our next webinar is scheduled for Tuesday, April the 12th at 2 o'clock. And our theme is Cannabis and Pain Management Part 2. Note the time of that session. That Thursday, April 12th session is at 2 o'clock. Usually our Tuesday sessions are in the evening, but we're doing this one in the afternoon just because of speaker availability. So just make a note of that we'll be seeing each other at 2 o'clock. With that brings our webinar today to a close. Once again, big thank you to Robert and to Alexandria for speaking today. Thanks to all of you for joining us today. And I look forward to seeing you all in a couple of weeks. Take care, everyone. Look forward to seeing you all in a couple of weeks. Take care, everyone.